Hello, and welcome to Noon Conference hosted by MRI Online. Noon Conference connects the global radiology community through free, live educational webinars that are accessible for all and is an opportunity to learn alongside top radiologists from around the world. We encourage you to ask questions and share ideas to help the community learn and grow. You can access the recording of today's conference and previous Noon conferences by creating a free MRI Online account. You can also sign up for a free trial of our premium membership to get access to hundreds of case-based microlearning courses across all key radiology subspecialties. Today, we are honored to welcome Dr. Stephen Rowe for a lecture entitled Current Radiopharmaceutical Theranostic Applications in Nuclear Medicine. Dr. Rowe completed his medical degree and a PhD in chemistry at the University of Michigan before undertaking residency training in diagnostic radiology and nuclear medicine at Johns Hopkins. He spent 7 years on the faculty at Johns Hopkins before recently moving to the University of North Carolina, where he continues his research in molecular imaging of GU oncology. At the end of the lecture, please join Dr. Rowe in a live Q&A session where he will address questions you may have on today's topic. Please remember to use the Q&A feature to submit your questions so we can get to as many as we can before our time is up. With that, we are ready to begin today's lecture. Dr. Rowe, please take it from here.
All right, thank you so much. It's really a pleasure to be joining you today. I'm down here in beautiful North Carolina, and it's just a great day to talk about radiopharmaceuticals and theranostics. The last time I was here a couple of months ago, which some of you may have also been at, we were focused on prostate-specific membrane antigen and its use in prostate cancer, mostly on the diagnostic side, although we talked a little bit about the potential theranostic applications. Today, we're going to more broadly look at theranostics. We'll start out with a brief discussion of the sort of I-123, I-131 MIBG pair for metastatic pheochromocytomas and paragangliomas. We'll segue from that, I think, hopefully smoothly, into somatostatin receptor expressing tumors, which can include paras and pheos, but we think of more today in terms of midgut neuroendocrine tumors. So things like pancreatic neuroendocrine tumors or duodenal neuroendocrine tumors. And the use of the gallium dotatate, lutetium-177 dotatate theranostic pair, where we're going to leverage lutetium instead of I-131 to deliver our beta particles. And then from there, we'll head back to the prostate cancer realm because, of course, PSMA theranostics is really going to be the kind of the high volume driver of theranostics worldwide, just because of so many men that have prostate cancer and the percentage of them that will eventually progress to metastatic disease that would be amenable to treatment with PSMA targeted theranostics. And again, we'll talk about sort of a little bit about the diagnostics, which is going to be at both F18 and gallium-68 labeled radiotracers, and then our current regulatory approved therapeutic agent in prostate cancer, which is also going to be lutetium-177 labeled, and the fact that there are other things in the pipeline, that prostate cancer is kind of driving that because, again, it's so common. And so we'll touch on maybe some of the emerging ideas that are there for what happens when patients don't respond to the current theranostics, and what do we have sort of in the hopefully near future that may be able to help those patients. Broadly, we'll again, maybe I can reset here just so we're all on the same page. So theranostics fundamentally comes down to the use of a targeted diagnostic radiotracer that shows us that a given target is expressed or that a given tumor has an affinity for the diagnostic agent. And that implies that the therapeutic agent will also be effective. So there's the origin of our word theranostic. It's really an example of precision medicine at its finest. We are figuring out how to get the right agent to the right patient at the right point in the treatment of their disease. And in some ways, this is nothing new. We've been using iodine-123, iodine-131 since at least the 50s for treatment of thyroid cancer. But it's really coming into its own now that we have things that aren't just sort of iodine. They're designed molecules that had big medicinal chemistry programs behind them to really try to optimize them and allow us to most effectively treat patients. And the approved agents, again, are for pheochromocytoma, paraganglioma, midgut neuroendocrine tumors, and prostate cancer. When I tend to say approved, I often mean U.S. Food and Drug Administration approved. I practice in the U.S. That's what I'm most familiar with. There may be various agents used around the world that either within a regulatory framework or potentially outside of a regulatory framework, in situations where there may be compassionate use doctrines at work. So let's jump right in and talk about pheochromocytomas and paragangliomas. This is often our tumor of sort of 10%, right? So 10% are bilateral in the adrenals, 10% are extra-adrenal, 10% are malignant, and I think there's a whole bunch of other 10% that approximately apply to pheochromocytomas. This used to be something that nuclear medicine had a very important role in the initial diagnosis of, and we'll look at a couple of examples of that. But quite honestly, magnetic resonance angiography, CT angiography, have gotten so good that they often do a great job of characterizing these tumors. And I think that from a purely diagnostic standpoint, in terms of a primary tumor characterization, nuclear medicine has taken a little bit less of a prominent role in that. And here's an example of a right adrenal pheochromocytoma, incredibly avidly enhancing. As you can see, just on this is an early arterial phase, and this tumor is just enhancing like crazy. So that's very characteristic of our pheochromocytomas. When nuclear medicine was maybe doing a little bit more on the diagnosis of the primary end, and perhaps also pointing for how we're going to move into a theranostic paradigm in this disease, we were using a lot of I-123 MIBG. This, of course, has a normal biodistribution, so you should expect to see it in the salivary glands, variably, but often fairly intensely in the heart, liver, spleen, kidneys, adrenals. It can have uptake in brown fat. There's clearance through both the colon and through the urinary system. And then there's also very variable physiologic activity in other normal structures. But this is, of course, why we would make use of it, is that it can identify pheochromocytomas and paragangliomas with I'd say moderate contrast, maybe. On the axial here, it looks like fairly high contrast, although you can see on the planar the uptake doesn't sort of knock your socks off the way maybe a targeted PET radiotracer might. But nonetheless, this does still have a role, and I still see cases where perhaps MRI wasn't determinate or couldn't make a definitive diagnosis, and we want to try another non-invasive approach. I-123 MIBG might still have a role there. But again, this talk is mostly about theranostics, and we want to focus on that. So when a pheo or a para goes bad and it begins to metastasize, which is not a common phenomenon, but does happen, we can still do whole body staging with I-123 MIBG. I would say this is becoming, again, a less common thing that we might do out of course. Many of these tumors will have FDG uptake. Many of these tumors will have dotatate uptake, which we'll talk about in a little while. But nonetheless, I-123 MIBG can still provide us facile whole body staging of a metastatic para or pheo. And that gets us to what we can potentially do then with that in the theranostic space, which is to, instead of using I-123 MIBG, we can use high specific activity I-131 MIBG, which is marketed in the US under the trade name Azedra. And it's FDA approved for therapy of what is admittedly a very rare disease. Now, this is so rare that I think the economics of sort of producing Azedra and administering Azedra have started to curtail its use to the point that my understanding is this won't be commercially available for much longer. But that doesn't mean it didn't have an important role to play, and that it hasn't, again, kind of pointed us in a good direction. This was one of the early approved theranostic agents, and it is it has helped at least a handful of patients with what is not only a rare disease, but typically a very symptomatic disease. and a disease that is almost inexorably progressive. These patients often have horribly labile and difficult to control blood pressure, just like a patient who may have a primary and non-malignant pheochromocytoma. And the phase 2 trial that actually led to FDA approval was specifically based around or had a primary endpoint of actually decreasing the number of antihypertensive medications that patients required. That primary endpoint was met, and hence the agent was approved. But that really sort of leaves us to, I guess, question, would there be overall survival advantages? Does this improve patients' quality of life? We think it does. We think those things are probably true, but those were not specifically tested in a pivotal clinical trial prior to the approval of Azedra. There are patients that do have very, very nice objective responses to this agent. This is a slide from my colleague, Dr. Lil Solness, who's the Nuclear Medicine Division Director at Johns Hopkins. And this was a patient that participated in a clinical trial prior to approval. You can see here there's an arterially enhancing lesion in the left lobe of the liver. That lesion becomes less enhancing and distinctly smaller 12 months after therapy with Azedra. So this patient has had an objective response, at least in this one lesion, but that wasn't either what the clinical trial was testing, and may not be an overly common thing that we see in patients. But what we really hope to do is abrogate their use of antihypertensives, and hopefully by that improve their symptomatology and quality of life. Now, as I noted a couple of slides ago, commercial availability of Azedra going forward isn't necessarily something that's going to be guaranteed. And again, it makes sense. This is such a rare disease that it's hard to have just this incredibly expensive sort of niche or boutique therapeutic for it. But I remain hopeful that what we'll eventually be doing is identifying those patients with metastatic paras or PHEOs whose tumors express somatostatin receptors. This again is a nearly universally expressed in well-differentiated mid-gut neuroendocrine tumors. Tends also to be expressed in other kinds of neuroendocrine tumors, although potentially to lesser degrees. We've long leveraged somatostatin receptor expression for the diagnostic end of things. So folks on the call may remember indium-111 pentatriotide or Octreoscan, which for decades was used in the evaluation of somatostatin receptor expressing tumors. I think pretty much everywhere worldwide, or at least many places around the world, have now gone to gallium-68 dotatate, a very similar molecule, only labeled with a PET radiotracer. And actually, both agents have very high affinity specifically to subtype 2 of the somatostatin receptors. And dotatate provides very, very high contrast, high spatial resolution imaging because it is a PET radiotracer. And although you can use actually high doses of indium-111 pentatriotide or Octreoscan as a therapeutic, that has really fallen out of favor. And we're pretty much universally using lutetium-177 dotatate as a way to deliver beta particles to tumors and hopefully control those tumors in that way. Very briefly, the dotatate biodistribution is seen here. I present this because we'll discuss a couple of pitfalls that to interpretation that we just want to be aware of. Generally not going to be an important thing when you've got a widely metastatic patient who's going to be a candidate for lutetium-177 dotatate. But again, we do want to be aware that not everything that has uptake on a dotatate scan is necessarily a neuroendocrine tumor. In terms of normal biodistribution, the pituitary gland, salivary glands, thyroid, spleen, adrenals. Spleen and adrenals tend to be the hottest things on the scan. Kidneys are both, there's both binding to the kidneys and also filtering through the kidneys, pancreas, liver, and prostate. So again, with paragangliomas and pheochromocytomas, we've had access to the I-123 MIBG, I-131 MIBG theranostic pair. But hopefully, again, we'll be able to transition some of these patients over to to eventually the gallium dotatate, lutetium dotatate theranostic pair, which would currently be off-label use of lutetium dotatate, but many of these patients do have somatostatin receptor expression on their tumors. And so here's an example of a patient who had a metastatic paraganglioma. You can see on the I-123 MIBG planar imaging, we see at least a couple of sites of abnormal uptake. We see that much clearer on the gallium dotatate MIP image. Now, in all fairness, the I-123 MIBG image is planar. It's not going to have nearly as much information as the MIP image would. But I think we do get a sense that the MIP image is just much cleaner. It shows us subtle things that I don't think we were ever going to be able to find with I-123 MIBG imaging. And on the CT scan, things that may be very subtle or even occult on CT, we see those as having very high uptake on the accompanying PET, which again drives a very high contrast resolution for this particular imaging agent. And here's a patient. This would certainly be a rare situation who had a familial syndrome. She had a succinate dehydrogenase mutation that tended to drive the formation of paragangliomas. And here you can see she has multiple sites of abnormal uptake in the neck and perhaps extending down into the upper mediastinum. And again, these lesions have incredibly high uptake on gallium dotatate PET. And gallium dotatate PET really should be probably subsuming a lot of things that we may have used MIBG or even other agents for, and this is across the board in PHIOs, paras, and even neuroblastomas that dotatate really has high sensitivity for these lesions. And because lutetium dotatate has become so widespread in its application, again, identifying these patients that have high dotatate uptake allows us to potentially put them down a pathway where they can hopefully have access to that therapeutic agent. I think it's sometimes shocking how extensive patients' disease is if all they've had is anatomic imaging prior to getting a dotatate PET, and we do have to, I guess you could say, have faith that dotatate really is showing us the true extent of disease. Here, I would say this sagittal attenuation correction CT scan doesn't really show us anything that would lead us to believe that this patient has widespread bone metastases from a midgut neuroendocrine tumor. Yet that is the case, as you can see in the sagittal PET and fused PET CT images. As I said, I did want to touch on a little bit on the pitfalls of gallium dotatate imaging. I think every one of my trainees who has ever read their first gallium dotatate scan is always turned off by the fact that there's no brain uptake like there is with FDG, and then there's this generally very intense uptake in the pituitary. And so there's always a thought on their part that somehow this pituitary uptake must be abnormal. That is an expected finding. Inflammatory conditions can have dotatate uptake. Again, something we just need to be aware of. And here you can see a patient who had biopsy-proven pulmonary sarcoidosis with at least moderate uptake in their mediastinal and hilar lymph nodes. That is actually on-target binding. So various immune cells, including macrophages, will express somatostatin receptor. So this isn't sort of off-target binding to something that isn't somatostatin receptor. It just happens that that inflammatory conditions can have somatostatin receptor expression. And then we wouldn't want to mistake a splenule for something like a peritoneal implant if we're doing a staging examination on patients. The spleen, again, is a very high uptake organ, and splenules mirror that. And then I would suppose I would be remiss not to mention what I think is probably the most famous pitfall of gallium dotatate imaging, which is that the dorsal anlaga of the pancreas, the Uncinate process primarily, has higher somatostatin receptor expression than the ventral anlaga does, and so you will see higher uptake in many patients in the Uncinate process. That can be relatively focal and mass-like. So it really is something to watch out for. Again, maybe not for patients who are being selected for theranostics, where we're usually looking at patients with relatively high volume metastatic disease, but certainly in the interpretation of the scan and the gallium dotatate scans, we want to be aware of this. All right, so that all brings us to lutetium-177 dotatate. In the US, the trade name for this agent is Lutathera, and that's often what we'll refer to it as in kind of day-to-day in the clinic. It's these are patients who, up until the advent of Lutathera, really had very little in the way of reasonable therapeutic options. They would typically be started on cold octreotide, which in its long-acting form is often called sandostatin, and it's a once monthly sort of depot injection that the patients get. Almost everyone will progress on that, and often in relatively short order. And prior to the advent of lutetium dotatate, those patients would have gotten chemotherapy as second-line therapy. Some still do, although at least in the US, the practice has mostly switched to using lutetium dotatate as the sort of second-line agent. I should note that is how the FDA approved it. They did not approve it as a first-line agent. So again, most patients will still get octreotide, cold octreotide, as sort of their first agent, and then upon failing that and progressing, they'll go on to receive lutetium dotatate. And so this there's really a number of studies that underlie this, but there's one that we'll focus on. So at the meta-analytic level, I think we knew that lutetium dotatate, and even other things like lutetium dotatok, lutetium dotanoc, lots of sort of variations on that theme, with essentially either the same or very similar peptide components of the theranostic with sort of different chelators for the lutetium. And again, at the meta-analytic level, we knew that this was working. There's at this point, probably 25 years of generally retrospective data from the European experience with this agent. We know that some patients will have very long responses to this, that treating patients repeatedly with this can be an option in some scenarios. But the FDA approval in the US was really based on the NETTER-1 trial, which was a multi-center prospective phase three pivotal clinical trial carried out at a number of sites, primarily in North America and Europe. And what certainly got the FDA's attention and would have spurred the approval was that patients had an improved progression-free survival and an improved overall survival relative to standard of care, which was typically cold octreoscan or octreotide. So cold octreotide. Now, many of the patients getting dotatate will continue on their cold octreotide. There's probably some anti-tumor efficacy with that agent, and it also helps control symptoms. And that's maybe something I haven't emphasized up to this point, but that we should talk about. These pancreatic neuroendocrine tumors, even sort of relatively indolent metastatic tumors, many patients will have carcinoid syndrome, or they may have release of various hormones that have profound effects on their quality of life. You will meet patients who have carcinoid syndrome, who have such sort of difficulty controlling their bowels that they can basically never be far from a toilet. And these patients become it's almost like they'll never leave the house because they can't leave the house because they're just sort of on the toilet all day. That is a horrible quality of life. And even if you can't necessarily buy someone an improved overall survival, although again, lutetium dotatate does that, you can potentially relieve their symptoms and give them back that quality of life, in addition to a little bit of quantity of life. But quality of life is a significant driver for many of these patients. Now, there's more recent data, and I won't dive too much into the weeds on it, that shows that ultimately, if you give it enough years, these Kaplan-Meier curves eventually come back together, and that simply speaks to the fact that these patients do have a terminal illness, and most of them will eventually progress and die from this illness. But I don't think that takes away from the fact that, at least out through the follow-up period of the NETTER-1 trial, there was an improved overall survival, and an improved progression, and a significantly improved progression-free survival. And then many patients will tell you just really heartwarming stories about how receiving this agent really improved their quality of life quite dramatically. And I do want to focus a little bit on, I guess, on the practical aspects of the NETTER-1 trial and what it means for what we do in clinic. So again, based on that trial, there was an FDA approval, and many of us are using this in our clinical practices now. And the things that I think we should emphasize, and when I talk to patients, the things I tend to emphasize are that their tumors may not get any smaller. There's actually only about 8% of patients will have a sort of RECIST 1.1 objective imaging response to the use of Lutathera, which doesn't sound very good. But 70% of patients, give or take, will have a good response and will have a progression-free survival interval after using Lutathera. So the objective response doesn't really track with what we see in terms of tumor control by this agent. So that's important. And many patients that I've seen won't have an objective response. Their tumors will all stay kind of the same. But again, that symptomatic relief that they get, it is still very satisfying to treat them, and the patients are very happy. There are toxicities associated with Lutathera. They aren't necessarily toxicities we would immediately identify, but there are hematologic toxicities, and in particular, platelets seem to be susceptible to dropping while on therapy with Lutathera. So we watch platelets very carefully. Ideally, we like the platelets to kind of be above 75 when we're treating patients. Of course, it's even better if they're above 100. But many patients will have a little dip in their platelets. It's very rare that a patient would actually need something like a platelet transfusion. And then we also watch their renal function very carefully. This isn't so much that we think that the amount of radioactivity they're going to get is going to lead to a nephropathy over the time course that these patients have to live. It's much more that if they take a hit to their renal function for some other reason, and we have to remember these are patients with generally stage 4 and often widely metastatic disease. They're often frail. They may not be hydrating well on their own. These, if that renal function drops, and particularly if it gets below a GFR of 30, treating them with 200 millicuries of a Theranostic beta-emitting radiopharmaceutical that's primarily renally excreted will lead to sort of added toxicities in other parts of the body. So then your hematologic toxicities may really be ramped up. So I have a pretty hard floor at a GFR of 30, below which I would be highly reluctant to treat a patient. Maybe there would be a circumstance that would come along where I would consider it, but generally that's sort of the again, kind of a hard floor below which I don't think we should go. So let me switch gears entirely then and talk about kind of another success story within Theranostics, and again one that I believe would probably be of general interest to the audience, and where things are going to get very interesting in terms of how we deliver Theranostics and how we move forward, because up until now what we've been talking about are relatively rare diseases. In the US, there are a few thousand mid-gut neuroendocrine tumor patients a year, and so a big academic center might treat a couple to a few patients a month with something like Lutathera. Whereas prostate cancer worldwide, we're up over 1.2 million cases being diagnosed every year. In the US alone, I think we're at about 280,000 a year. Now, many of those patients are going to be cured by surgery or by radiation. But for those who go on to develop a metastatic and lethal phenotype of prostate cancer, they need systemic therapy. And that systemic therapy has traditionally sort of gone through androgen deprivation, then either concurrent or followed by second-generation anti-androgen agents like abiraterone and enzalutamide, and then eventually on to taxane-based chemotherapies. which have also been sort of moved up further and further in the course of the disease. And some patients with relatively high volume metastatic disease will start ADT and taxane-based chemotherapy as their upfront systemic therapy. And as patients progress through and fail those various therapies, PSMA targeted theranostics is one way that that those patients might continue to derive benefit from systemic therapy. And while many prostate cancer patients are cured early in the disease, there's probably at least 40,000 patients a year in the U.S. that are or 40,000 patients right now that would be eligible for treatment with a PSMA therapeutic. And all of a sudden, we're now in the tens of thousands. And as clinical trials continue to read out positive for use of PSMA therapeutics in metastatic hormone-sensitive prostate cancer, pre-chemotherapy, hormone-sensitive, perhaps even neoadjuvant therapy, as all of those things start to come onto the table, that population just expands and expands. And quite honestly, my main worry is, are there enough nuclear medicine physicians and or radiologists and or radiation oncologists that are interested in this to the extent that that we can get all of those patients treated with what is an efficacious and well-tolerated therapy? So let me start with PSMA PET, because that's how we're going to be selecting our patients. And here where I talk about PSMA PET, I'm kind of following the NCCN guidelines, look at it, that although gallium PSMA 11 has often been used to select patients in clinical trials for PSMA therapeutics, that any PSMA targeted PET radio tracer, and in the US there's now 3 approved. That's gallium PSMA 11, F18 DCF-PYL, and RH PSMA 11, F18 RH PSMA 7.3. That any of those radio tracers from the view of the NCCN can be used to select patients. So we're going to just take a view that sort of all PSMA PET is the same, and I think that's a reasonable way to approach it. What we do know with PSMA PET, at least on the diagnostic side, is that there's a moderate sensitivity, very high specificity for preoperative nodal staging. We know that there's a high detection efficiency for sites of biochemical recurrence, and we believe we're effective for guiding metastasis-directed therapy in patients who have low-volume metastatic disease. But then the big thing is selecting patients for PSMA-targeted therapeutics. Very briefly, here's a couple of patients with high-risk prostate cancer being preoperatively staged. We can see that one of those patients truly does have localized disease. The other has unsuspected systemic disease, which we were able to pick up because of the high sensitivity of PSMA PET. For biochemical recurrence, we can find small little local recurrences that here shows up on MRI, but certainly would not have shown up on CT. And obviously, being a local soft tissue recurrence would not have shown up on bone scan. And then oligometastatic patients. So there may come a time where we do leverage lutetium PSMA therapeutics for patients with more limited volume metastatic disease. Most of the patients we're seeing in clinical practice have high volume metastatic disease. And I think there's at least some thought that why not give these patients a shot with external beam radiation therapy if they have low volume disease? So this patient had only a solitary visible recurrence on PSMA PET, did get SBRT, and PSA became undetectable despite not starting systemic therapy. We see patients we think might have been a candidate for metastasis-directed therapy with limited volume apparent metastatic disease on something like a bone scan, who truly have widespread systemic disease. And so this patient shouldn't get SBRT. This is a patient who should be a candidate for lutetium PSMA therapy. There's a couple of different agents that have been pretty widely used worldwide. I think the one on the left here, lutetium PSMA 617, has been the more widely used, and the two best clinical trials that have been done worldwide so far, at least that have been published, have been done with PSMA 617. That's the trade name for that is Pluvicto in the US. So we'll often just refer to, we're sort of developing the habit to kind of refer to this as Pluvicto therapy. Presumably, lutetium PSMA INT is going to be known as something different. I think our expectation is that will be FDA approved, knock on wood, hopefully in the not too distant future. And that's currently the pivotal clinical trial with that agent is, I believe, is accrued out, but has not been read out yet. Let me show you what I suppose amount to a whole lot of forest plots here, but I think each of them has an important point to make, and these are sort of at a meta-analytic level. Although I'll show you data from the pivotal clinical trials. I like this sort of meta-analytic data format because it includes meta-analyses of all the toxicities. So we'll talk about that. And again, this really forms kind of a basis for how I talk to patients who are candidates for receiving this therapy. So I will tell them that in terms of an objective response rate, which is a PSA drop of at least 50%, I expect somewhere around 40% of patients who are metastatic castration resistant post-chemotherapy, often post-chemotherapy, but some of this data is with pre-chemotherapy metastatic castration resistant. But all of these patients are metastatic castration resistant. I expect 40% of those patients to have that 50% drop in PSA. That is that doesn't sound all that great, I suppose, right? It's less than 50%, but these are heavily pretreated patients who, again, have often seen taxane-based chemotherapies. They've progressed on all of those things, and so now they're kind of at the end of the road, being treated with this relatively new agent. And so, in that context, I think a 40% objective response actually sounds really encouraging. Somewhere around, and I should mention, we've never found a difference between lutetium PSMA 617 and lutetium PSMA INT in terms of their efficacy, at least not a statistical difference between them. A lot of our data trends towards lutetium PSMA 617 being potentially slightly more efficacious, but again, that has not held up as a statistical difference between the two agents. So whichever one I could get a hold of and whichever one I have access to that I can use in clinic, I would feel comfortable using either one. Currently, lutetium PSMA 617 is the FDA-approved agent, and that's what I use in my own clinical practice. In terms of any PSA decrease, about 70% of patients will experience a PSA decrease. Now, of course, that ultimately means that somewhere around 30% are going to have a PSA increase on therapy. I think it's a little controversial as to exactly what that means right now. And generally in clinical practice, we try not to check a PSA before we've given a couple of doses of therapy. Now, some of my oncology colleagues are a little antsy and are checking PSAs pretty often, but we do believe that patients can have a short-term bump in PSA after the initiation of therapy, and that many of those patients will go on to have a good response to therapy. So I'd be hesitant to discontinue lutetium PSMA on the basis of a small bump in PSA over the first couple of doses of therapy. I think when you have a patient whose PSA is truly skyrocketing, very, very short doubling times, many of those patients are ultimately not going to benefit from lutetium PSMA. I would potentially, again, give them at least 2 doses to see how they're doing. But when you really have those rapid increases in PSA levels, those patients really do need to be encouraged to have additional chemotherapy if that's possible. Get chemotherapy if they haven't had it before. So we do want to watch the PSA levels, but again, I'm sort of a believer in trying to give at least 2 doses to every patient before we pull the plug, outside of relatively extenuating circumstances. But nonetheless, I guess what I emphasize out of this data with patients when I'm talking to them is, again, that I'm a believer in this therapy. I believe it's effective, and as we're going to see over the next few slides, I believe it's very well tolerated. But I also know that at least based on our current understanding of what we should see on a PSMA scan, where we should see high uptake, we should see high uptake and relatively homogeneous uptake between tumors. We don't want to see a lot of heterogeneity between the uptake in different tumors. that still 30% of those patients are going to be primarily refractory to this therapy. So that's unfortunate. I think we'll get better over time based on nomograms, based on machine learning that helps us better incorporate aspects of the patient chart along with their imaging. We're eventually going to get better at selecting patients, and this number will go down and our previous numbers will go up. But at least right now, about 30% of patients are going to be primary refractory to our therapy. As I said, this is generally a fairly well tolerated method of therapy. Somewhere around 20 to 30% of patients will have some kind of anemia. This gets harder when you're dealing with patients who are anemic to begin with. And so patients that have hemoglobins less than 8, the current guidelines would suggest we probably need to either wait for that hemoglobin to recover, or that these patients just may not be candidates for this particular therapy. That can be really hard. Obviously, patients distinctly don't want to hear that, but we don't necessarily want to make patients transfusion dependent and sort of not only not extend their life, but then sort of add on kind of a big ding to their quality of life by treating them with this. So I'll treat patients down to a hemoglobin of about 8, although below 10, I really do start to get a little worried about them, and I at least have a conversation with them that we have to keep a very close eye on their hemoglobin, and that at some point they may require transfusions to either continue on therapy, or they may not be able to continue on therapy and they may still need transfusions. For grade 3 or 4 anemia, this is essentially, if we properly select our patients, this is very uncommon. But again, if you are treating patients that are down in kind of that danger area with hemoglobins of 8 to 10, you may push patients to transfusion dependence and unfortunately sort of permanently shut off their bone marrow's production of red blood cells. So it is you will potentially see grade 3 or 4 anemias. It is uncommon, but not zero. Don't see a lot of nephropathy in these patients, and not that there isn't significant dose to the kidneys. I just think the kidneys are relatively not all that susceptible to radiation. And so again, over the time course in which these patients will be alive, which for many of them is a matter of months, I don't think nephropathy is a significant it should significantly dissuade us from treating them, or a fear of nephropathy should dissuade us from treating them. Again, I typically will not treat a patient with a GFR less than 30. Down to 30, I'm keeping an eye on their renal function. But again, I'm more worried about other things that may hit their renal function. Food poisoning, where they really become dehydrated and they go into an AKI. Things like that will then sort of allow the lutetium PSMA to run rampant and cause more toxicities. Those are the things I worry about more than actually directly damaging their kidneys through use of this agent. Grade 3 or 4 nephropathy is distinctly rare, and again, that may be a function of these patients not having very prolonged life courses after this. There's probably something to the fact that if all these patients lived for 10 or 15 or 20 years, we would start to see the impact on kidney function more so than we do in the current environment. Xerostomia, not really a problem with the lutetium-based agents. If you hear about xerostomia with PSMA, it's usually in the context of actinium-225 PSMA, which is being used primarily in an investigative way in the US. It is also being used clinically in parts of Europe for sure. I think the toxicities associated with that are really quite severe, and certainly any grade xerostomia is going to be quite a bit higher with that agent. As an alpha emitter that also has daughters that emit alphas, it is really quite a hopped up agent. We'll talk a little bit more about that in just a minute. Grade 3 or 4 xerostomia, again, essentially unheard of with lutetium PSMA. I think my clinical experience anecdotally is that a fair number of patients will describe kind of a little bit of either jaw soreness or noting that they have maybe subjectively just a little bit of a dry mouth. And so far, our approach has been to recommend that to eat a sour candy or something like that that's really going to get their saliva going. And then many patients seem to do fine just with that. Again, grade 3 or 4 xerostomia would be unusual. Grade 1 or 2 xerostomia is maybe not that unusual, but pretty easily taken care of in my experience. Now, there have been two pivotal clinical trials. Both have used lutetium PSMA 617. One of them was the Therapy trial. This was a 2-to-1 randomization against cabazitaxel. And the initial findings from the first paper on the Therapy trial were that better tolerated than cabazitaxel, and a higher percentage of patients had a biochemical response by PSA with lutetium PSMA 617 than cabazitaxel. So it was both more effective and better tolerated. So it really looked like this was going to be kind of a home run for lutetium PSMA 617 as opposed to cabazitaxel. However, over the entire time course of that trial, there was not a difference in overall survival between patients treated with cabazitaxel and those treated with lutetium PSMA. I think that was disappointing for all of us on the side of lutetium PSMA. I think there's still something to the idea that even if these are equivalently effective, that the quality of life with lutetium PSMA is better. But I will also admit that lutetium PSMA is very expensive, and employing an expensive agent in tens of thousands of men that is not going to show an overall survival advantage is a huge burden to the healthcare system, and something that we clearly would need to figure out. Now, perhaps a little bit more on the brighter side, the other big clinical trial or pivotal clinical trial that was done, the Vision trial, and I realize these graphs probably project kind of small, but the Vision trial found that lutetium PSMA 617 plus best standard of care versus best standard of care alone. So here you can see that it's maybe not quite as rigorous and that it's not a randomization to another agent like cabazitaxel, but perhaps more reflective of kind of a real world clinical practice, that there was an overall survival advantage predicated on a progression-free survival advantage. And there was also an advantage in terms of freedom from skeletal events such as compression fractures or other sort of painful events that a patient may undergo. So it was the Vision trial, which was partly conducted in the US, that led to the US FDA approval of lutetium PSMA 617, which again, we now use as Pluvicto in routine clinical practice. And I would say that even at our center here at UNC, where I would consider us a relatively small center in the sort of PSMA therapeutics landscape, we're treating several patients a week. I think the big new infusion center out at UCLA can do like 28 patients a day. So maybe we're starting to kind of build that capacity out, that as this therapy, which again had showed an overall survival advantage in patients who are metastatic castration resistant and post chemotherapy, as we move into the pre-chemotherapy setting, as we move into the metastatic hormone sensitive setting, we really are going to have to work hard to kind of meet the capacity and get those patients seen by a nuclear medicine physician or other physician and lined up and getting them treated. It is going to be a Herculean task as we move forward over the next few years. And then the pooled data from Therapy and Vision, certainly positive, although that's kind of driven by the Vision results, which Vision was also a larger study, so it's maybe weighted a little bit more in this pooled analysis. I do want to show a couple of example cases because although the actual infusion process with lutetium PSMA 617 is relatively easy. You have to have a shielded setup, and you still want to very slowly infuse this in case you blow a vein or have an extrav, it would potentially be a disaster. But that infusion is relatively straightforward. It's everything that comes before the infusion that isn't straightforward. And I know the words here are small, so I don't intend anyone to read this, but this is just sort of our patient workflow for these folks. And you really need the right personnel. So in addition to someone familiar with therapeutics and with administering them, you need to have all the mechanisms in place, just like an oncologist would, of a somebody like a nurse or a very specialized technologist who can interface with the patients, kind of initially screen some of their information, flag certain things for the physician that would be supervising the infusion, make sure that the patients have their scans, make sure that the patients are following up on their labs, placing lab orders. A lot of these things now can be done in nuclear medicine or again, other specialties that might do this, so long as you have the right personnel. But hopefully we're moving past the point where we just expect our medical oncology colleagues to do everything for us, and all we are is kind of the infusion center. We really want to actively co-manage these patients. And that again means, fortunately, does mean investments on our side in the proper infusion setups in infusion centers. But then I think the thing that tends to get forgotten about are having the right personnel on board. And again, that's by no means just the physician. There are really other people that have to be involved to make this happen. As I said, I do want to show you a couple of example cases. I think this would be one such case where this patient has widespread metastatic disease. It's all very avid, but it doesn't entirely take up all of their bone marrow space. I think you could believe that this patient could be treated, and that although they may have a hit to their bone marrow, that you're not definitely condemning them to sort of transfusion dependence for the rest of their life. So high volume disease, but not overly high volume disease, very high uptake on PSMA PET. This patient's going to be a really good candidate for treatment with lutetium PSMA. This is a patient that maybe wasn't as good a candidate. He had a couple of sites of very, very avid disease, so relatively low volume, but a couple of sites of very avid disease on an initial PSMA PET. We thought he was a great candidate. There was a supply shortage of Pluvicto for a couple of supply shortages of Pluvicto for a while, and that interrupted his plan to get treated with lutetium PSMA 617. So he went and he got cabazitaxel, and when he came back, his lesions weren't as PSMA avid as they should be. And what I mean by that is, you can see that he has a couple of lesions on his follow-up PSMA PET, a couple of which are new, that are below sort of a background liver uptake, which is what a lot of us use as kind of a ballpark for the degree of uptake that these lesions should have. He had sort of, if you will, been promised that as soon as this became available, he would be back on the schedule. We had, I think, some misgivings about treating him, but also didn't know that he wouldn't benefit. However, his PSA just kept right on rising. So I think that you can see patients who get something like cabazitaxel may not have a lot of PSMA expression in their lesions, but then over time that PSMA expression comes back. And maybe the thing to do in some of those patients is to wait for that sort of recovery period. It's hard to wait, though, when a patient does have metastatic disease. So again, unfortunately, this patient wasn't a success story. This patient also wasn't a success story, and ultimately we treated him with one dose, but then he had unfortunately, his disease was just too widespread and too progressive. It's if you look here, his bone marrow is diffusely infiltrated with disease, and he did not really have any bone marrow reserve, very tenuous to begin with. He also has lung metastases that aren't particularly avid. So again, this patient doesn't really strictly meet criteria, but also didn't have any other options. And so in a shared decision making between the patient and the oncologist and our group in nuclear medicine, said, let's give it a shot. But again, his disease was so rapidly progressive, and his bone marrow was already shot, and so we were not able to get more than one dose in this patient. And all of that brings us to, and I'll wrap up in the next couple of minutes because I do want to be able to take any questions. Gets us to what do we do in those patients who aren't going to respond to lutetium PSMA? One option is, again, treatment with alpha-emitting radio tracers. This has most commonly been actinium-225 PSMA. You can see here this patient who was quite honestly, my understanding was basically on death's door, winds up with an undetectable PSA after a few rounds of actinium. But I think what you also notice is that all the salivary gland uptake disappears in this patient. So those salivary glands are being treated by the therapeutic as just other tumors, and it wipes out those other tumors, if you will. So this is where we start to hit real toxicities with these agents. Lots of things have been tried, such as injecting various agents either directly into the salivary glands or into salivary gland ducts, cooling pads on the face, things like that. Although those things may impact things like scintigraphy, they don't seem to affect the patient's symptoms. So there's maybe a few different ways to go, and hopefully we can get these things into patients in the near future. But different scaffolds, different alpha emitters, lead-212, astatine-211, those kinds of things are all in the pipeline, and hopefully again we start to see those in the near future. I'll sort of skip this, it's a little arcane, and just wrap up really quickly with the idea targeted radio tracers form the basis for multiple theranostic agents, several of which are now regulatory approved. Patients with these cancers can benefit either from prolonged survival or abatement of symptoms. So it's not necessarily all about survival, although that's a very important part of it. And we do need new agents to either improve our efficacy or improve our toxicity profiles. And with that, I thank you for your attention. I guess I only left a couple of minutes here, but I'm certainly happy to take any questions. And I'm going to open up the. I'm going to stop sharing my screen and open up the Q&A and see if anything's here. All right. So our first question: is it possible we use diagnostic pheochromocytoma with F18, F-DOPA, and go on therapy with MIBG? Both tracers have the same mechanism of uptake and catecholamine metabolism. I think that's a really interesting idea, and I don't disagree that that you can potentially confirm a target expression with something that may be different than the actual agent that you're treating with, and I think we maybe even see that with say the PSMA agents. Chemically, something like F18 DCFPYL is distinctly different than something like lutetium dotatate. Although they have one sort of moiety in common, and that moiety drives the binding of both. So yeah, I don't think we necessarily have to feel kind of chemically constrained to have the exact same molecule. My concern would be more what our source of I-131 MIBG is going to be going forward. So that may be kind of more the problem than what we select with. And then second question: in your experience, best time for an F18 PSMA scan, 90 or 120 minutes. We have issues with bladder and ureter uptake. Yeah, so a couple of things to unpack there. So there is some data that as you go to later and later time points post-injection, you can potentially find subtle things that you may have missed at earlier time points. I will say the label in the US is, I think, anywhere from 45 up to 90 minutes. I may not have those numbers exactly right. We do tend to scan at 1 hour at my institution, only because it fits in very neatly with the F18 FDG workflow that sort of dominates our oncology practice. So I think there are sort of practical advantages to 1 hour. I do think you may find some subtle things as you go out to those later time points. And I wish I had the flexibility in my pet center to potentially go to those later time points. And in terms of bladder and ureter, yeah, absolutely, it can be tough to read around in those. So there are places that give Lasix. We don't, and that's partly because particularly our patients who are post-prostatectomy, they're already having trouble holding their urine. You hit them, wallop them with a dose of Lasix, and you're going to wind up with a lot of radioactive urine on your PET scanner in all likelihood. So we don't do that, although people do, and I don't think it's unreasonable. There have been studies done where patients are catheterized. I can tell you, if you take most men with prostate cancer, they're not going to want you to put a catheter in them. And in those, so we kind of just do our best. We have the patient void right before they get on the table, and then we start our acquisition from the mid thighs. So hopefully we're only a couple of minutes post their last urination by the time we hit the pelvis, and hopefully that minimizes the amount of at least urine in the bladder that you have to contend with. With the ureters, it can be challenging. I think it's very incumbent upon us in terms of anatomy to make sure we've got the anatomy right, and then you can potentially, if you're really stuck on ureter versus a lymph node, if you have the flexibility, you could also go and reacquire the pelvis to kind of make sure that that if it moves, it must have been ureter, and if it's still there, it's probably a lymph node. A couple more questions, and I'll try to get through these fairly quickly. So, is MIBG more sensitive than gallium dotatate neuroblastoma? I don't believe so. I think gallium dotatate is what we're eventually going to all be doing. Although that is not the guidelines recommendation in the U.S. right now. I think in Europe, a lot of those patients are now imaged with dotatate. And then one last question: any thoughts on FAPI agents and their promise? Yes. I think FAPI as a diagnostic tool is definitely on the horizon, and I hope we have widespread access to it in the very near future. I remain unsure what its ultimate therapeutic applications might be. I fear that when we go and we basically wipe out the cancer-associated fibroblasts, that at least some of those cancer-associated fibroblasts may be kind of holding the tumor at bay, and we don't necessarily understand enough about the biology to know if that's a good thing or a bad thing. So those all remains to be seen, but I agree. The fibroblast activating protein, both inhibitors and other things that bind to that, I think are super promising. I do apologize. I think we're a minute or two over time. So I think I'll probably have to kind of stop answering questions, but I really appreciate everyone logging in, and it was really a pleasure to speak with you all today, and hope to see you back here in the not too distant future. So thank you all again. Really, I hope everyone has a great day.
Oh, thank you so much, Dr. Rowe. Thank you again for sharing your lecture today and coming back and joining us at MRI Online for the noon conference. And thank you to all for participating in our noon conference today. You can access the recording of today's conference and all our previous noon conferences by creating a free MRI Online account. Be sure to join us next week on Wednesday, October 25th at 12 p.m. Eastern for a noon conference replay featuring Dr. Mahan Mather's lecture, Imaging of the Gallbladder and Bile Ducts, followed by a live Q&A with Dr. Mather himself. You can register for this free lecture at mrionline.com and follow us on social media for updates on future noon conferences. Thanks again and have a great day.